Silveira a hacer su presentación. Muchísimas gracias.
Thank you. Second try. Let's go. My name is Rui. I'm not a plastic surgeon yet. I'm a med student at the Federal University of Sergipe, Brazil. And I'm a trainee at the Northeast Center of Plastic and Reconstructive Microsurgery. I'm here to talk about our surgical approach for correction of anosmia, a transnasal endoscopic nerve transfer for olfactory neuroepithelial stimulation. Early results. Introduction. Olfactory dysfunctions affects about 3 to 22% of general population. One third stem from viral upper respiratory infections, most commonly following COVID-19. Over 80% of patients experience some kind of olfactory dysfunction, and recovery period normally lasts 6 to 8 weeks. However, 7% experience permanent anosmia. Let's talk about damage. Increasing evidence suggests that COVID-19 related olfactory alterations result from damage to the olfactory mucosa. Most affected cells are non-neuronal, such as supporting, basal, and Bowman's gland cells. Here is the 5 degree of degeneration from Yamagishi classification, 1998. In stage 1, the patient has a normal olfactory mucosa. Stage 5, the patient has a completely loss of olfactory mucosa, and the majority of our patients stays in stage 3 and 4. In stage 3, there is an atrophic mucosa. In stage 4, there is no olfactory receptor cells. We perform a biopsy at the beginning of every surgery to evaluate the patient's mucosa histologically and how these patients evolve after surgery. Theory. The proposed procedure is based on the surgical technique reported by Viterbo at 2018, with some modifications. First one, an end-to-end neuropathy between the sural nerve graft and the supraorbital nerve graft, or supraorbital nerve, sorry. The second one, the removal of the epineural of the terminal part of the sural nerve graft to achieve a greater nerve contact surface. And the third one, acknowledge of anatomy and endoscopic endonasal approach to provide a better positioning of the fascicles in a region with a higher concentration of olfactory neuroepithelium. The main physiological explanation for this procedure is not clear, but here is the 3 important factors. The nerve growth factor that is released because of the presence of the sural nerve graft. The second one, the babysitting mechanism that prevents more degeneration. Here is the article published in 2000 that shows the normal saphenous nerve with the mean axon count and compared with the saphenous nerve used as a graft, which had a higher mean axon count because he adapts himself in the area that he was placed. And the third one, the brain plasticity to interpret the new signals. Okay, our study design, the prospective cohort objectives: evaluate the changes of olfactory neuroepithelium of patients with olfactory disorders and correlate them with the response after the nerve transfer surgery. So far, 12 patients were operated. Inclusion criteria were persistent olfactory disorders, clinical treatment lasts more than 6 months, regardless of etiology, and all patients must undergo through the rapid olfactory test from Connecticut Chemosensory Clinical Research Center for our data analysis before and after surgery. The patients had no other option to overcome the anosmia, so that's why they were this surgery was made. Sorry. Exclusion criteria: comorbidities that could affect the results of olfactory training, such as uncontrolled diabetes and hypertension. So the procedure. 2 small incisions were made with approximately 2 centimeters at the bilateral upper eyelid, inferiorly to the eyebrows, to expose the supraorbital nerve. Another 2 small incisions with approximately 2 centimeters as well were made bilaterally at the lateral portions of the nasal pyramid to expose the bone. And a tunnel is created using a cutting drill to allow the passage of the nerve graft. Number 3 is the harvest of the sural nerve graft. 3.1 is after the removal of the epineuron from the terminal part. Number 4 is the passage of the nerve graft through the hole that was made. The number 5, this is the schematic view of the nerve graft entering in the submucosal tunnel that goes through the posterior part of the superior conch and stops progressing at the anterior wall of the sphenoid sinus. That's the area with the higher concentration of olfactory neuroepithelium. Number 6 and 7, that represents what I have just said. Number 8, that's the end-to-end neural feed between the sural nerve graft and supraorbital nerve. And the final one, 9, is the final aspect of the patient before the sutures. Results. No patient showed a worsening of the initial olfactory symptoms. The patients with no progress were older, except this patient here with 38 years old that had some episodes of uncontrolled diabetes. And 2/3 of our patients improved the olfactory function, and actually the numbers should be higher, like 75%, but one of the patients who were developing well got COVID. This is it. This is our team that I'm looking to work with and learn from. Thank you.